right, everybody. So we are starting off with our first YouTube lecture on advanced patient assessment. And the first couple of these lectures are really kind of a review, and I'm not sure if we really want to say in depth, but hopefully a good review of things that we covered in regular patient assessment. So, or your first round of patient assessment, I guess. Hoping I don't have too many interruptions. You'll hear me probably pause out. I'll have to pause mainly because of the dogs, generally, or other distractions at home, as you can imagine. So this slide's about 44 slides. Anything over 50, I think I'm going to try to break down in like part 1 and part 2. Otherwise, it's just a lot to download onto the computer, upload, or whatever. The other thing I wanted to say is on Friday, the 17th, we'll talk a little bit about a couple little homework assignments coming up. You will have an MRE on Friday, so I'll put that up. That will be available just on Friday. So we'll, I just have some other things I want to talk to you about in person as much as what that looks like. Okay, so let's get moving. So vital signs are kind of our first things we'll be talking about. As you know, we kind of we call a pulse ox a vital sign too. It's kind of the 5th vital sign, sort of a respiratory. So we're looking at body temperature, respiratory rate, heart rate, blood pressure, and pulse ox. Okay, so these are different tools that we're constantly assessing and looking at to help us determine what is going on with our patient and how can we treat them. Okay, so always be thinking about that as different parts of the puzzle. So if we are 37 degrees Celsius, we are considered afebrile without a fever. Hyperthermia at being greater than 37. So when we see hyperthermia, we think about, if we think fever and we wonder, is there an infection going on? Okay, so that's generally where our first thinking goes. So remembering that our hypothalamus helps regulate our core temperature. We like to keep it at 37 because that's where everything is optimal in our bodies. If we see that it's hyperexia, I think that's how you say it. Anyway, exceptionally high fever of greater than 41. And then hypothermia, obviously hypo being low, you also have to be concerned of a decreased metabolic rate. Looking at our symptoms of low temperature mainly, we're going to have everything's just going to kind of slow down. So, hypotension, they're confused, they're shivering because they're trying to bring their temperature up. Okay, so when someone's cold, you are going to see them vasoconstrict. So they sometimes do therapeutic hypothermia, generally getting them down to about 32 to 34 degrees Celsius for a post-arrest situation. So they'll do that for like about 12 to 24 hours, and it seems like it has improved the neurologic outcomes if we can get them cold. Also keeping in mind that if we are looking at a fever, how it increases our metabolic rate. Okay, so every 1 degree increase Celsius increases our oxygen consumption by 10%. Okay, so remember that little tidbit. So every time we increase our degree by 1 degree Celsius, it increases our O2 consumption by 10%. So you might go see your patient and their heart rate's gone up, their respiratory rate's gone up, their pulse ox has gone down. You're doing your main troubleshooting. One of the things that if I can't get it to go up, or we just talked about different things that are going on. Hit my 100% suction button once just to kind of see if it actually does respond to oxygen. Sometimes they might need to be suctioned. You take a listen to them. You're looking at their airway pressures. You're looking at the return tidal volumes. I'm talking obviously patients on ventilators. And then it might be because they're starting to spike a fever. So always kind of keep that in your mind. All right, respiratory rate. So that's going to give us some information, keeping in mind our normal values. So make sure you're familiar with those and the term tachypnea and bradypnea. I'm not going to go over those. You can read them there for yourself. Sorry, I don't know why my voice is kind of funny. I really talked a lot today, so pay for yelling at my dogs. Keeping in mind that your diaphragm is your primary muscle for respiration, and that your inspiratory effort is an active and exhalation is passive. Okay. Best to try, to take your respiratory rate when you're not really staring at your patient. Like when you're taking their pulse, you can just kind of keep your fingers there for a few minutes or a few seconds rather, and just kind of get your respiratory rate. Along with respiratory rate, I think it's really important to observe their actually respiratory pattern, and we'll talk about that actually coming up in the next slide. So I'll kind of go into a little bit more depth about that. And again, what are things that can cause a higher respiratory rate? So we think fever, some type of maybe a metabolic acidosis is going on. Possibly they're hypoxemic, or they have pain, or there's anxiety. It can actually be, more than one thing. If the respiratory rate's low, probably the more common thing that I think of in the hospital is that they probably have had too much sedation. That's why we definitely want to monitor their end-tidal CO2 post-op if they're getting pain medications, if they're on that PCA, or even if they're on an epidural. So that's something that we monitor to make sure that they're not getting too much sedation. Are they cold? Is there a head injury? That's a good reason too. So just a heads up, hint, hint, you're going to need to know 2 causes of each for your MRE. Okay, 2 causes of each. So 2 reasons why you'd be tachypnic and 2 reasons why you'd be bradypnea. Okay, so little clues there. All right, breathing pattern. So make sure you understand and know the definition of each of these, because I know these will come up on a multiple choice question. So page 16 in Desjardins kind of goes over these. So eupnea, I think. This is just normal rate, normal rhythm. Bradypnea, slow rate, normal rhythm. Tachypnea, fast rate, again, normal rhythm. Okay. Absence of breathing, obviously apnea, without A, being without, just like afebrile, apnea, apnea. So absence of breathing. Hypoventilation. So this is kind of one that sometimes trips people up a little bit. So it's decreased rate and depth. Okay. So obviously your CO2 is going to be rising. Okay. Hyperventilation. Same thing where you're actually having a decrease in your CO2. So you have an increased rate and an increased depth. I'm going to pause you for a second. I'm going to check on something. Okay, so moving on. Now talking about the different patterns. And I do believe we have talked about these before too. So Cheyne-Stokes breathing. Cheyne-Stokes breathing, so you have an abnormal and progressively faster and deeper. They kind of slow down and they go apneic. Okay, so Cheyne-Stokes you may see a head injury patient, or so a patient with ICPs, possibly a drug overdose or stroke, even heart failure. Okay, so make sure you're familiar with the causes of Cheyne-Stokes breathing. So again, I usually think you'll see it like with a head or a trauma, stroke, increased intracranial pressures, ICPs. Drug overdoses, sometimes heart failure. All right, Kussmaul breathing. So Kussmaul is generally seen in a diabetic patient in a DKA, trying to get rid of their CO2. So it's just kind of a increased rate and depth. So the goal for that patient is trying to get rid of their CO2. Or they may have some other type of a metabolic process going on where they're trying to get rid of CO2. Biot's breathing is another one. Kind of resembles a little bit of Cheyne-Stokes, with just mainly because of that apnea period, but it is you're still having that fast and deep with just all of a sudden irregular pauses. Just for some reason it just stops and they just stop breathing. Okay, that's generally a central nervous system issues, damage to the medulla oblongata. Again, it could be a stroke, trauma, or any type of pressure. Okay, but the biggest differentiation between Biot's and Cheyne-Stokes is Biot's doesn't like taper up or taper down, it just abruptly stops. Alright, again, talking about heart rate. So not only are we paying attention to the rate itself, keeping in mind your reference ranges of 60 to 100, bradycardic, tachycardic if you're higher, tachy if you're slower, brady. And the main things that we need to be concerned about is, you know, how are they presenting? You know, are they, and trying to figure out why they are that. Okay, so looking at their heart rate, seeing if it's regular. Okay, it's definitely another thing that we're obviously looking at to see what type of rhythm that they're in. We want to know if their sinus node is working properly. So if their sinus node is working properly, then they're considered to be in a sinus rhythm or a regular rhythm. Okay. So if it's not, then we need to see, you know, if there's some coronary artery, you know, get an EKG, seeing if there's some coronary artery perfusion compromise going on. Maybe their oxygen is low, maybe they're having electrolyte imbalance. Okay, so for your MRE, again, hint, hint, you need to know 2 causes of each, 2 causes of tachycardia and 2 causes of bradycardia. Okay, also keeping in mind the strength, so you're able to figure out if you have a bounding pulse, so you're checking their pulse rate and it's bounding, which kind of indicates, you know, high volume, high blood volume. Weak and thready would be low blood volume. So that's kind of telling you, you know, what's your force of your contraction. Okay, giving you some idea anyway. Again, you want to make sure that you know your common sites. It's kind of interesting because I'm just going over patient assessment right now. For some reason, these classes sometimes for me overlap a little bit. So, pardon me if I seem like I don't mean to be talking down, but if it's like, I might think it's like the first time you've heard of it, is because I'm, you know, kind of switched in my head where who am I talking to? But you guys have had this before, so. And I know we went over it. So you want to make sure you know those 9 pulse points. Hint, hint, this is also a question on your MRE. Okay, so make sure you have these down. Your temporal, carotid, apical. Oh, that's the one that was missing on the... Huh, I was just noticing that. They had like a facial one or something in that diagram. Apical. That'd be boring. So you have the 9 here. You know, I usually top to bottom. So make sure you're able to recall those. Okay. So again, thinking of different reasons. Why would you have tachycardia? Okay. Some of them are similar to tachypnea, hypoxemia, also anemia. Okay. Fever again, anxiety, stress, hemorrhage, low blood pressure because your body is trying to compensate to maintain the cardiac output, so you increase your heart rate. Dehydration, okay, you're dry. Different medications, exercise. So just make sure you're able to name 2 causes of each. And then bradycardia, being cold, obviously fit athletes or being athletic. Those are interchangeable terms. Sleep, a head injury again, vomiting because you're increasing the intrathoracic pressure when you're vomiting. You can get that vagal response when you vomit. You hold that pressure in your chest. Age, possibly, and drugs. Okay. All right. Being familiar again with the terminology of pulsus alternans or pulsus paradoxus. Okay, what these mean. Okay, so pulsus alternans is a normal rhythm, but the strength values. So maybe you have like you're feeling the pulse, you're palpating the pulse, and feels really strong, and then it kind of fades and it feels really strong, but maybe on the rhythm strip, maybe they're still having a normal rhythm, but it's just kind of, and sometimes if you have it significant enough, you can see a little bit of a drop in the blood pressure. All right, pulsus paradoxus, that is usually associated with severe asthmatic episode. So it decreases its strength during inspiration and then kind of goes back to normal during exhalation. Again, due to the increase in thoracic pressure. My dog's being a brat. I think I realize why they act up. I'm thinking, as I'm intervening again with them, is because I think they think they're jealous that I'm talking to somebody and I'm not talking to them. Maybe that's it. Crazy dogs. Okay, so make sure you know these terms and what causes the difference. That's kind of a hint, I remember on one of your little scenarios too, that the patient, I believe, was experiencing pulsus paradoxus, I want to say, and so that was kind of giving you a hint on what's going on with them. All right, then again, we're looking at now our blood pressure in its normal ranges, okay? Don't get too hung up on some of those numbers. I know the last class, they were upset something with a range, but it was kind of a range that was within the normal range that was given, but slightly outside. So I just get kind of focused on that. So just remember, these are reference ranges, okay? So basically, when we're talking about blood pressure, this is the force exerted on your arterial walls, okay? So your systolic being your top number, okay, that's the squeeze or the contraction, and then your diastole or diastolic is the relaxation pressure. And if you subtract the two from each other, okay, so let's say you have, like for the example on the slide there, 100/60 for your blood pressure. So your pulse pressure then is the difference of 100 minus 60. So your pulse pressure then would be 40, okay? So your normal range between those two numbers is 40 to 60, your pulse pressure, okay? So if you're having a higher number, so you're kind of out of that range, okay, so let's say you're greater than 60, then you might want to think of causes of increasing pulse pressure can be like valve regurgitation, stiff aorta. Generally your pulse pressure is going to increase with age as your arteries and your blood vessels start to stiffen as you age. They kind of lose their compliance. Decreased pulse pressure, so if you don't have much of a difference between those two numbers, so less than 40, then you need to look at, what's going on with the heart. There's some poor heart function going on, possibly cardiac tamponade. Okay, so the difference between the two is pulse pressure. Right, so blood flow then, we're referring to stroke volume. I can't honestly remember how far along you guys are. I'm like, I know I taught you first semester, which was math and science, and oh yeah, cardiac EMP. So we have gone through definitely stroke volume. So you should kind of remember that, and you'll be hearing it over and over, probably almost every semester. So Stroke volume then is the blood, the amount of blood that is ejected from the ventricles with each heartbeat, and then we multiply that by the heart rate, and that's going to give us our cardiac output. Okay, so our heart rate will increase if our stroke volume has decreased. Okay, and one of the things we'll talk about more too as we get into CV diagnostics is we actually look at cardiac index, which takes into consideration body surface area, which would be kind of more specific to each person. Okay, so we want to make sure that we have adequate blood flow to make sure that our tissues are getting their adequate oxygen and nutrition. So thinking of why, obviously decreased cardiac output, you're going to have decreased blood flow. But so you're looking at like ventricular failure, you're also looking at hypovolemia, you just don't have enough volume going through, or bradycardia, obviously, unless your stroke volume for some reason is to recognize that it should contract, your heart should contract harder. So we want to look at some different reasons. So if we have increased cardiac output, we would look at possibly tachycardia or increased blood volume. Okay, so for decreased blood volume, decreased cardiac output related to blood flow or blood volume would be ventricular failure and decreased blood volume, so hypovolemia. We're just kind of talking about our pulse oximeter, our friend, normal ranges, and again, these are normal sea level. Okay, so 95 to 99 is normal sea level. Okay, I have some reference ranges that kind of help. So looking at the book on page 18 in Desjardins, where you're looking at what you should expect your PaO2 to be in those different areas of percentage of SAT. So if you're looking at 95 to 99%, you should be at about 75 to 100 for your PaO2. I want to just double check really quick to make sure that they are on that page. So the pages that I'm referencing to are actually out of, just to make sure that they're out of your clinical manifestations and assessment of respiratory disease, that Desjardins book, that kind of purplish gold brownish color. Okay, so disease chapter 2, and it says that here in the calendar too. So if you look at page 18, it'll show you those the reference ranges of what your PaO2 should be given those saturations. So again, mild hypoxemia, you should have about 60 to 75. Moderate hypoxemia, then your PaO2 would go down to 50 to 60, and severe hypoxemia of less than 85% would be less than 50 on your PaO2. So pretty much unreliable readings once you start getting less than 80%. We need to really kind of look to see what's going on with our patient. They're probably not having good perfusion most likely at that time. So these again, MBRC uses the sea level, so keep that in mind when you're taking your boards. Okay, so depending, it took me a while to when I first, I've been here for over 30 years, but 90% being acceptable. Okay, so you want to really make sure that it's actually still considered mild hypoxemia at 90 to 94% when you're at sea level. Okay, so just keep that in mind when you're studying for your boards, preparing for your boards, and you'll hear that several times. All right. Now, as we're looking, okay, we have this systematic process of looking at our lungs. Okay, so we should be kind of going through like a little checklist as we're evaluating. Right, so I just created a Sign Up Genius for you guys. I'm not sure, it was giving me trouble as far as trying to make more. I made 8 slots for each, basically 8 slots for the 24th of each time period, the first being 12:30 to 2, and then the second 2:30 to 4. We're going to go over the breath sounds tape. We'll look at chest tube, so it'll just be kind of a little potpourri of different information. So it's not really officially a checkoff per se, though we do need to call things checkoffs when we meet. So it's just kind of a, however, I think it's imperative that you have the ability to listen to these different breath sounds and feel comfortable. All right. So looking at topography, so just kind of being able to identify different landmarks basically, and this is on page 19. So we're looking at the ribs in your spine. We're looking at where your first rib is, locating that right below your clavicle. Okay, and I know you guys spent time. You have your beautiful drawings still up in your classroom. I showed them off to the A or the new B group the other day when we came in. They were very impressed. I think especially Molly's, yours was beautiful. So you could probably take those down if you'd like when you come back to class next week. So we can put up, well, I don't know if I will put up new ones obviously, but anyway, so your C7, so if you're looking at the back of your neck, on your back of your spine here, your C7 then is where you have that kind of spinous process, kind of sticks out the most. And then your T1 then, so your thoracic rib, your T1 is where your first rib extends, okay, right below that C7, okay. And then just being familiar as far as like terminology, what it means to be mid-sternal, mid-clavicular versus left versus right side, mixed axillary, so mid-scapular, so just being able to relate to what they're referring to when they're talking about different things like that, as far as like x-rays or what to able to understand the terminology basically. All right, and then your fissures, where they lay, and I know that it's kind of interesting on our sheep lungs. They I guess with pulmonary physiology, they really thought that there would be more distinctive fissures in the lungs as far as the sheep lungs, but you really don't see that per se. I mean, they have the different lobes, but as far as so I guess that would be, if you were to lay them flat. But anyway, so knowing your fissures helps for good auscultation, so you're able to help identify what area of the lung that you're listening to. Remembering another hint on your MRE, that you're anteriorly, so on the front, the apices of your lungs, so the very tops of your lungs, extend about 2 to 4 centimeters above the clavicle, and then down to about the 6th rib, okay, anteriorly. Posteriorly, that looks like an expansion from about T1 to T10, okay. So basically anteriorly, and I know this is on your MRE, anteriorly your ribs expand from about 2 to 4 centimeters above your clavicle to about the 6th rib, and then posteriorly from about T1 to T10, okay. Let's see, on your left side, you have the 2 lobes. The oblique fissure runs anteriorly to about the 6th, or along the 6th or 7th mid-clavicular to about the 5th mid-axillary, and then posteriorly runs to about T3. On your right side then, so I started with the right side of the picture, which is your left lung obviously, and then your, I know it's confusing, the left side of the picture is your right lung. Read your words there. So when you're looking at then on your anterior, so you're looking at different views here basically. Posterior being on the right, anterior being on the left. So your 3 lobes on your right, having your right upper, middle, and lower. Your horizontal fissure runs from about the 4th rib of the sternal border to the 5th rib mid-axillary. Your oblique fissure runs from about the 6th to 7th mid-clavicular and runs around to posteriorly to about T3. Okay, so those should be in Desjardins also. On this next diagram here, what we're looking at is your top left, obviously anterior, kitty corner to the bottom, then is the back posteriorly, so diagonally, and then on your upper right is actually your left lateral, so you can see how it's facing, and then on your right lower, or rather left lower, is your right lateral. So this is just kind of a I think a neat way to do it. You know, take a marker, draw on yourself. That's kind of the idea of the t-shirt that they sort of used to do, but I guess they decided that was okay, whatever. So basically we are looking for the different, oh, I know what I was going to say. So when we're doing the inspection part, okay, so when we're doing inspection of our patient, just kind of think of some of the things that you're going to be looking for. Inspection, so you're viewing with your eyes. Okay, so just kind of loading your brain here a little bit. So some of the things that we should be looking for. Okay, we're obviously looking for some abnormalities. Are we seeing accessory muscle use, a weird ventilatory pattern? Is the patient pursed lip breathing? So this will also be on your MRE. And these go over on page 21 in Desjardins, the brownish purple book. Do you see retracting? Do you notice nasal flaring? Do they seem to be having pain where they're not able to take a deep breath? Is there a chest tube in place? Have they had a recent trauma? Are they splinting or kind of breathing weird where they're not taking as deep of a breath? Do they seem really uncomfortable? Is there abnormality in the chest shape or configuration? Looking for extremity findings like clubbing. Do they have a cough? So generally within the first, minute or two that you're walking into a patient's room, you kind of just get used to just kind of doing a little checkoff thing in your list, or in your head rather, of what you're seeing. I guess the first thing, are they is the rate high? Can they talk to me? Are they struggling to talk? Are they having pain? Are they grimacing? Are they, holding themselves in a weird position to breathe comfortably? Are they tripoding, using accessory muscles? Are they pursed lip breathing? If they're a COPD patient, they're generally on oxygen. Are they retracting, especially when you're looking at kids? Nasal flaring. So these are all just kind of things you take a quick kind of snapshot and, oh, they're coughing. Every time they take a deep breath, they cough. So these are all the things that constantly are going through your head while you're with your patient. And then again, why? All right, so on the next slide, we'll start talking about palpation. So, unfortunately, we probably don't do this enough. I know that physicians will, and if you do experience like a bad pneumonia on one side or something, as far as seeing about, using your hands to see about the bilateral chest wall movement. Animals. So if you're looking for chest wall symmetry there and expansion by putting your hands on the chest wall, I think that's kind of cool to see if you actually have a diminished movement on the affected side. Also looking for making sure that your trachea is midline. You definitely may feel some tactile fremitus if they have really thick secretions, so you'll feel like that vibration over those thick secretions. You would also have vocal fremitus would be increased again with thick secretions. Just thinking of it having a medium for that sound, and then the feeling of those secretions to kind of travel over. Okay, The other thing that you definitely would like to look for is crepitus. I found it on occasion on patients that have recently been trached, or if they had a central line put in, or if they've had a chest tube put in. You'll kind of walk your fingers across. It's the best way I can kind of describe it. Your little fingers just kind of march across very gently and walk to see if you can feel like a little crackle kind of feeling. You can actually kind of squish it down. And I'm not sure if you guys have this video, but there is a link, I think, on the smaller screen. So I'll be putting this up. This is a YouTube link that you'll be obviously listening to. But if you look at the original PowerPoint, sometimes it's easier to visualize those links. So I think you guys have seen this. I know I'm just trying to remember. So this is subacute emphysema. It's a very bad case of it. The nurse tries to like push it out of these different holes that he has here. He must have had some chest tubes put in. I believe he's a post-op lung reduction. Just kind of an interesting, but you will see faces like this sometimes with it. All right, moving on to percussion. Okay, so for percussion, we're kind of seeing if we're have a normal sound or if it's hyper-resonant. Mainly, it's one that you would definitely hear kind of loud, kind of hollow, and then remembering that would be over areas of like COPD with air trapping present, a pneumothorax. So you want to know what would be the causes of a dull or hyperresonant. Okay, so as you're doing this, you're comparing both sides, the anterior and the posterior, and then the left side, the right side, and it's just a kind of a skill that you have to practice as far as like how you do it. You take your middle finger on the area, and then just kind of a quick tap, tap, tap. You can try it on yourself or try it on a family member since we're all home. Maybe I should try it on my dogs. Anyway, so dull, flat sound, kind of high pitch, short duration, pleural thickening. Okay, pleural thickening, and effusion, atelectasis, consolidation. Okay. Hyperresonance, again, pneumo, air trapping, COPD. Okay. All right. So this again, I believe, is a little video clip. All right, auscultation, and this is what we'll spend some more time on next week too. Yeah. So we'll do that on Friday the 24th. So what are we hearing? We're looking to see if we have normal breath sounds. Generally, a lot of times you'll hear people say they're decreased breath sounds, diminished breath sounds. That's usually, you'll hear that in hyperinflation, so your COPD patients. So on the diagram there on the lower right, and ventitious breath sounds. So anything that wouldn't be obviously bronchial or bronchiovesicular or vesicular or referred to as adventitious. I'm having a rough day today talking. So crackles, and then trying to figure out if they're coarse or if they're fine crackles, wheezes, inspiratory, expiratory. It is saying diminished, being kind of, but it could be diminished bronchial breath sounds, or mainly vesicular breath sounds that would be diminished. Stridor, that would be upper airway stuff going on, pleural friction rub. So these are all the different types here. So I'm just going to kind of go over some of my notes with you. So we're talking about normal or bronchial sounds. Those are the normal sounds that you would hear over the trachea. Okay. Bronchial vesicular are like in the main stem, and you're a little bit larger airways. Okay. Anterior, you're talking like first, second rib area. Posterior, you're talking like between the scapula at about the 1st to the 6th rib. Again, so those are your bronchial, vesicular, anterior, between your 1st and 2nd rib, posterior, you're listening in between the scapula, on each side of the spine. You're going to hear the breath sounds along there between about your 1st and your 6th rib. And then vesicular breath sounds are the ones when I was talking about more diminished. That's further out into your lung fields. So you hardly ever hear them say the term like, oh, I hear diminished vesicular sounds. I mean, bronchial we'll talk about more, but vesicular are just your normal breath sounds, and they're just diminished. It's often shallow breathing also can cause diminished breath sounds. So fine crackles are generally considered to be caused from atelectasis. So often people will maybe start listening to the lungs in the lower airways and in the back, in the bottom, the bases, because they think that possibly repeatedly taking deep breath that maybe you'll open up those atelectatic areas, and so you won't hear the crackles at first. So whatever you're comfortable with, listening. Coarse crackles are generally going to be more secretions or fluid. However, keeping in mind secretions and fluid can also cause wheezing, so it's not at all uncommon to have a combination of breath sounds. And you may hear one side a little bit different than the other side. You may have more wheezes on the right side and more coarseness on the left side, or just more coarse wheezes. That's another way that we chart, because you can kind of tell based on what's going on with the patient, what they're there for, that their wheezes are probably due to their secretions. Okay, and then kind of knowing their history, maybe it could just actually be just asthma, so then it's just more of a wheeze, like a tighter wheeze. You have to have a lot of practice with listening to breath sounds to really able to determine what it's caused from. Stridor then is generally always in your upper airway, post extubation, anything that's going to do with your upper airway. That's your more common one, croup. And then your inflamed pleural space is going to give you your pleural friction rub. So you're listening to like the pitch of these wheezes or these different sounds, the rhonchi, intensity, if it's diminished. You can have really loud, coarse wheezing, faint wheezing. You're also assessing for the I to E ratio, so you may have like prolonged expiratory wheezes. Okay, there's so many different ways that you can describe breath sounds. That's why it was always so frustrating when we switched to electronic charting, because you have like a drop-down menu, and you kind of have like ones that are already predetermined that you pick from, and sometimes it's like, no, I want to write my own, which you can, because there is a comment box where you can actually type in, but it limits how many characters you can type. But try to be as specific as possible on really what you're hearing. But those drop-down menus kind of limit your ability to explain sometimes. And then also you're going to obviously identify where you're hearing, what side, upper, lower, mid. So that's important too. All right, I'm trying my best to keep this under an hour. I'm not doing very good. All right, now we're looking at accessory muscle use. So looking at the accessory muscles of inspiration and the accessory muscles of expiration. So for inspiration, you're going to see your scalene, which is your neck area. It helps to elevate your first and second ribs. So that might be a COPD patient, or possibly somebody that has had a diaphragm that has been damaged or paralyzed or something. So that is generally the inspiration ones are often used to help because let me finish my thought. To help replace or assist the diaphragm. So again, the COPD patient with a flattened diaphragm that no longer has that muscle to help them out as well. So your sternocleidomastoids are long, run along each side of the neck. They help hold up your head, and they also help lift your sternum, and so they are what increases your AP diameter. So you would see that in your end-stage COPD patients. So they're larger than the scalene muscles. Your pectoralis major is the ones that you're going to see when patients are tripoding. Again, that also helps increase the AP diameter. And then your trapezius is in your upper back neck area. Helps kind of elevate the thoracic cage. So it might be kind of like a shrug on inspiration. That's what you'll kind of see if they're using their trapezius muscle. Again, that's in the upper back neck area. Then on your accessory muscles for expiration, your rectus abdominis, those are your abs basically, helping out your diaphragm. So kind of pushing the external and internal obliques, and then your transversus abdominis is underneath actually your oblique muscles. So again, those are helping the patient exhale. For those that are not able to have that elastic recoil back in their diaphragm. So this is, you'll be seeing pretty much your scalenes and your sternocleidomastoid on this demonstration, on this video clip. So again, if you minimize the screen, or if you go back to the Blackboard and look at the screen, or look at the PowerPoint that has all the links, the hyperlinks to it. Same thing with this one, you'll be able to see accessory muscle use. You can see some retracting, I remember going on pretty profound on this one. Alright, pursed lip breathing. You should know by now that that's helping create a back pressure to help keep the airways open. Generally, it's something that they kind of sort of learn to do on their own. They just kind of discover it, but if it's something that the patient, in pulmonary rehab, they definitely go over it with the patients and teach them how to do this, but you can teach them how to do it. You just kind of tell them to inhale through their mouth, exhale, or inhale through their nose, exhale through their mouth. Boy, I'm just having a rough day talking. I apologize. So it usually goes a little bit better than this. Anyway, so they're kind of like, kind of like she's doing in that picture there, just kind of slow exhalation. Inspire through their nose, they're wearing their oxygen. Exhale through their mouth, kind of get them to slow their breathing down. So if they're able to exhale fully with that pursed lip breathing, is creating PEEP, then they're able to take the next breath a little bit deeper, so it helps to reduce air trapping. Alright, talking a little bit more about substernal and intercostal retractions. So kind of seeing this more in severe restrictive lung disease, often definitely seen in newborns. They have a much more flexible thorax, so you can really see, it's pretty pronounced, it's pretty crazy when you see it, especially the newborns are like, whoa, is their chest wall made out of rubber or what? And then obviously patients with low lung compliance. So they really have to generate a greater than normal negative intrapleural pressure during inspiration, and that's what causes the tissues between the ribs to sink in on inspiration. So they have to generate a greater than normal negative intrapleural pressure during inspiration, which then causes the tissues between the ribs to sink in on inspiration. In the next slide here, if you look at your hyperlink, you'll be able to see retractions on these little kids. Nasal flaring, you can see this on this little gal. Again, more pronounced in children, just trying to increase the diameter to increase the flow. Okay, Flazell's law. Again, infants and small children, you'll see nasal flaring. And then just kind of identifying, again, what barrel-chested looks like, your increased AP diameter, why they call it the barrel chest. You can kind of see it on even the lateral diameter there, more so in the anterior posterior. And then some of the different spinal abnormalities that you would see, so different chest configuration, because these can definitely impact the lungs. So normal, obviously, kyphosis, or your hunchback. Lordosis is like the other sideways curve, or no, I'm sorry, more of a pronounced inward curve, so kind of like hyperflexed there, and then your scoliosis being your sidewards curve. So if I look at this x-ray on the right, I am seeing severe kyphoscoliosis, so it's both like the second person and the right, the far end person. So kyphoscoliosis can be a combination. And so would you call this obstructive or restrictive lung disease? Just food for thought. I hope you say restrictive. All right, pectus carinatum again is more of a kind of an increase, I guess, AP, kind of a bird chest. You have that kind of sticks out, kind of puffs out. They can have symptoms of shortness of breath, especially during exercise. The chest brace is sometimes used to help treat this. The Ravitch procedure, they have to remove cartilage and then reshape the chest wall, and they add bars to help stabilize it. Pectus excavatum is definitely where your chest is sinking in. Excavatum, I think of an excavator, like with the scoop, kind of scooped out part of the chest there. This can be mild, and it might just, physical therapy may help, or it could be moderate to severe where there's surgery. So one of our students, he's now no longer graduated, yay. He had pectus excavatum, and he had surgery. He showed it to us. Kind of cool. Cyanosis. Part of your MRE is list 2 abnormal extremity findings and what it could indicate. So cyanosis being one of them. Okay, and we'll talk about a couple more here in the next few slides. So you can see this is really quite pronounced, but you can see it in the little baby there. Definitely that's central cyanosis. So different causes of cyanosis is a decreased BQ ratio, chronic bronchitis, asthma, COPD, pulmonary edema, possibly a foreign body. So you have a decreased ratio and pulmonary shunting going on. You may have pulmonary edema, again I mentioned. Sometimes congenital heart defects can do this. That can give you a different mixture of your blood. Again, the shunting, venous admixture. Let's see, what else we got here? Most common finding that you'll see in severe respiratory disorders. Can also occur when your hemoglobin is reduced. Sometimes difficult to assess in poor light, and certain skin pigmentation definitely can be influenced by temperature. So just a few different side notes there. All right, clubbing. That is something you might find. Digital clubbing, often present in CF patients, so chronic respiratory disorders. Sometimes it can be hereditary, and it doesn't have any tie with the cardiopulmonary disease. So it's generally a chronic condition that these patients are clubbed or have clubbed fingers, clubbed fingertips, and clubbed toes even. Another extremity finding could be edema. Okay, what does edema mean? Generally means some type of heart failure, congestive heart failure, cor pulmonale. Could also be hepatic cirrhosis. Mild, can present in a mild state with people that are standing all day long, or in pregnant women. Generally, it gets better when you're, sit up and put your feet up a little bit. So you want to kind of press on the area with the edema. Usually it's about 2 to 4 inches above the foot for about 5 seconds. And then, a lot of times nurses as part of their evaluation, as far as like doing it on a scale, okay, like plus 1 to plus 4, plus 1 being mild, plus 4 being the most severe. So you want to kind of see if it if it comes back. So you remove and to see if the skin can bounce back. And if it doesn't bounce back, then it's more severe. So just a kind of a little side note that in the Nazi concentration camps, prisoners had edema because of protein malnutrition. Their albumin is key for fluid balance, so they end up getting edematous like this because they are low, their albumin level is low. Alright, another extremity finding, that's really not extremity, I'm thinking neck, but whatever. Distended, I guess it's not in your core, so distended neck veins, okay? So you might see this in patients with, so CHF mainly is your left heart failure, right heart failure is considered cor pulmonale, okay? You might see it in a severe flail chest, or a possible pneumothorax, or a pleural effusion. Of course, those have to be pretty pronounced. So venous return is decreased, so your central venous pressure is up. Cardiac output may also be decreased, and your blood pressure may be low. This is also, I believe, a video clip. Oh, look at it. If I go over here, it doesn't really work when I'm talking, but yeah, this is definitely a video clip, and you can see it more when you play it. The external jugular, internal jugular veins that are distended. Alright, a little bit about sputum, our favorite thing. So normally we produce, remember, about 100 mils of clear secretions, and our cilia help mobilize that and move it forward so we can cough it and keep it moving. So your cilia rate is about 2 centimeters per minute. So mucus has a purpose, basically, of helping protect bacteria. So we want to have some secretion, so that's why it's important to stay hydrated. So the normal mucociliary escalator, or also referred as a mucociliary transport, is essential in preventing infections and damage to lung tissue. So you want those little cilia to be moving. So you'll have patients that'll say, especially smokers that have quit smoking, that they feel worse now that they quit smoking because they're coughing up so much more stuff. Well, that's because that layer of like tar and nicotine and all those toxins have kind of finally gone away, hopefully, or the immediate impact of them, where their cilia are starting to come back to life again, so that the mucociliary transport escalator is functioning again. So it is moving that crud down there so that they can cough it up. All right, different types of sputum and color, okay? So kind of dark brown old blood. I remember mycoplasma kind of being one of the types of pneumonia. I don't want to say Klebsiella too, I have to look it up. But kind of old dark brown blood. Even a COPD patient can have really dark, nasty looking secretions. Bright red blood, I mean, depending on how much it is, it could be considered hemoptysis. then you're thinking more like TB or tumor. But even sometimes with patients with pneumonia, I know I had a question asked about that. You know, coughing really hard, you can burst one of those little capillaries and cough up, bring up a little bit of blood streaks, you know, just a little bit. But generally, your infections are kind of that yellow-green, nasty stuff, stagnant gram-negative bacteria, you know, H. flu, E. coli, Pseudomonas, especially Pseudomonas is nasty. If you have kind of that mucus-like layer where it kind of settles out, that's bronchiectasis, and even occasional the chronic bronchitis or the asthma patients might have that type of secretion because they really don't have as much of an infection process going on, the asthmatics, so it might be more of a white-gray. Pink frothy, I know we saw some of that, and again, it might not be really super pink, it might be just real pale colored. I think of on our sheep lungs, and we had this last time too with the new group. You could see some of the frothy stuff coming up. So pulmonary edema, copious is considered greater than 40 mils. That's you know, considered a large amount. You'll have those patients that will like to show you their secretions or save it for you, and they cough it up in a little emesis basin, and you're like, oh, thank you so much. Okay, we can throw that away now. Ooh. Tenacious, sticky, very sticky or adhesive, viscous, very thick, kind of like a rubber band, kind of like it strings out, kind of stringy, and then it snaps back. That would be viscous. Really gross, huh? Yellow or opaque, can have a little bit of, it looks kind of like a mix here with little clumps basically, so this is kind of mixed up with like saliva kind of in there, or a little bit of clear secretions, and you have like kind of flecks of it. Presence of white blood cells, or again bacterial infection. Okay, lastly, I didn't keep it under an hour, I'm just going over, I'm sorry. Our cough. Okay, so we want to know the stages of the cough. Remember, you have some type of agitation that happens. Okay, that's the first thing that kind of sets you off. Then you have that inspiration, your glottic closure, which is the compression of you know, closing off. Your glottic closure creates a compression, which then leads to that forceful contraction of the muscles in your expiration of coughing. So the different things, so you know, when we're assessing our patients, trying to figure out why do they have a cough. Okay, so you know, if it's is it a chronic cough? Have they been coughing like this for 6 months? You know, then you know, getting a chest X-ray. Is it a productive cough? Is it a dry cough? You know, where do you feel the cough coming from? Does it feel like it's more in your throat or more in your chest? Is it worse when you do something? Does anything make it better? So all the different things. If you've had an exposure, is it related to environment? So these are all the different things that we are assessing when we're looking at our patients. Okay, we can see that they're having a cough because they're having an asthma attack. We can see that they're having a productive cough, an exacerbation of COPD with maybe a bronchitis or a pneumonia going on. You know, again, asthma, is it you know, were they on the cold, or did they have a virus, or you know, on occasion it could be some type of a mass. Obviously, you know, we can stimulate the cough, which we would like to do. I mean, that's definitely something. If you don't have a cough when you suction a patient that's on a ventilator, that's not a good neuro sign. Okay, are we coughing a lot because of excess secretions? Do they find themselves coughing when they're laying flat in bed? Do they having extra fluid going on? Is it maybe cardiac related? So these are all the things that are going through your head as you're doing your assessment. Okay, we'll have more on Friday.